Hello, everybody, and welcome to the ATS Pulmonary Rehabilitation Assembly's Journal Club. My name is Katherine Menson, and I'm a member of the Assembly's Web Committee and an assistant professor at University of Vermont in the United States. Before I introduce today's article and speaker, I'll let you know that you can how to interact with the Journal Club. If you have a speaker connected to your computer or you're dialing in by telephone, you can click the mute on the Zoom panel. You can also raise your hand and we can help unmute you so that you can ask your question. If you don't have a speaker, you can type your question or comment into the question box, and committee members will be monitoring the chat for that. Alternatively, you can also post your question on X and to our Twitter handle at PR_assembly, and we will read it aloud. We really do like a lively discussion, so we'd appreciate any questions or comments you may have, and preferably we prefer to hear from you in person. All right, our Journal Club today is a review of high-yield topics relevant to pulmonary rehab that have been published in the past year, led by Professor Singh, who is the head of Pulmonary and Cardiac Rehabilitation at the University Hospitals of Leicester and NHS Trust. Professor Singh will now present her data. Thank you.
Thank you, Katie, and thank you for the invitation to do this. It's been a long time coming, hasn't it? And I put Journal Club 23, but I absolutely appreciate we are now in 2024, but I'm going to pick out a few key papers from 2023 to discuss with you. So, I mean, it was a good year for national guidance last year. We had the ATS evidence-based guidance and the British Thoracic Society guidance. And I know that you will schedule a session on the ATS guidance, so I'm not going to talk too much about that. I'm going to talk a little bit about the BTS guidance. It feels slightly inappropriate to dwell too long on the BTS guidance, given that it is an ATS webinar, but I just thought it would be interesting to look at some of the key areas and look at some of the similarities and differences, which will lead us on to a paper which looked at selection of individuals for telehealth interventions, and then finally looking at a paper describing a core outcome data set for pulmonary rehabilitation. So I'm sure none of you on this call need any reminding that the American Thoracic Society published this document. It was approved back in May 2023. There's always a slight lag before we actually get it into print, but it was very ably led by Carly Rochester and Anne Holland. And there's a whole group of people in the middle, including patients and methodologists who really contributed to this document. So if you haven't already read it, I would absolutely encourage you to read it. The second document, which took a different approach, and I will talk you through that, was a clinical statement by the British Thoracic Society. And it has quite an interesting history because pre-pandemic, we had put in a request to update the original 2013 statement to, in fact, be an evidence-based document, just like the ATS documents. Clearly, the whole pandemic threw a complete spanner in the works for so many reasons, and the BTS decided that because there was likely to be so many changes in the field of rehabilitation and so much more research, particularly around alternative models of rehabilitation, that actually they would prefer for us to do another clinical statement and then consider doing an evidence-based guidance in a couple of years' time. There's always a lag, isn't there, with trials and funding and that getting into publication to review as evidence. So that was their decision, which is probably not an unreasonable decision given how the pandemic has potentially really made quite a difference to how we deliver rehab, or certainly made us think about how we deliver rehab. So I've just sort of tried to identify what the similarities, and the differences are. And one is, as I've said, an evidence-based guidance with 6 clear PICOs, so areas of really greatest clinical interest, particularly to the American group of people that are operating in this field. absolutely based on library searches, largely based on systematic reviews where they were available, and that was supplemented by any more randomized control data. And there was, the PICOs, as all of you know, were absolutely pre-specified, and then the data was considered, obviously, and then an evaluation framework was used to develop the final recommendations. On the other hand, the BTS was quite different. It looked at areas of sort of uncertainty, if you like, particularly in this post-pandemic environment. And the content was developed to reflect really those dilemmas. But of course, it had to absolutely go through an approvals process through the Standards of Care Committee. And individual sections were drafted by group members. So we, of course, went back to the evidence, and there was some support from the BTS to help us with those searches, but it wasn't exclusively based on the systematic reviews, unlike the ATS. Just like the ATS documents, there was a sort of a protracted but appropriate public consultation with that, and it was posted on the BTS website for public review. And then the layout wasn't that dissimilar in some ways to the ATS, in that there was an evidence review, not as systematic as the ATS, with clinical practice points and then research gaps within that. Now, this is a figure taken from the ATS guidance that identifies the 6 areas that were questioned. Ultimately, the recommendation and the strength of evidence. So, should adults with stable COPD undertake pulmonary rehabilitation? That's recommended with strong to moderate evidence. Similarly, level of evidence around the post-exacerbation population, again, strong to moderate. Adults with ILD, again, strong to moderate. And then the other area where it was strong to moderate, which is perhaps an area where there's some variation between the ATS and the BTS, is should adults with chronic respiratory disease undertake tele-rehabilitation? And again, that was strong to moderate. Where the evidence wasn't quite so strong was if patients present for pulmonary rehabilitation with pulmonary hypertension. It was sort of a conditional recommendation where we suggested participation in pulmonary rehabilitation, but the quality of the evidence was low. Similarly, there was a conditional recommendation around undertaking maintenance post-pulmonary rehabilitation, and again, the evidence level, just with pulmonary, as the same as pulmonary hypertension, the evidence level was low, despite the fact, perhaps on both of those counts, it seems absolutely intuitively the right thing to do. And these are the research recommendations that came out of the ATS document, and they were divided up into sort of broadly disease-specific areas, and then a second set of recommendations looking at pulmonary rehabilitation models. So the disease-specific ones were looking at pulmonary rehabilitation at earlier stages in disease, arguably at the point of diagnosis, which for some people, of course, isn't the early stage of their COPD. Looking at interventions to improve referrals into pulmonary rehabilitation, the old challenge of the optimal timing of rehabilitation post-exacerbation, particularly around the time of a hospitalisation. And we all know that uptake to that is particularly poor. So again, a suggestion that we should look at improving strategies to increase uptake in this space. And then in the same area of exacerbation, most of the evidence, of course, is for COPD, but other chronic respiratory diseases experience exacerbation, so we equally should be looking at that. Then new exercise training strategies for those with ILD, and those possibly pulmonary rehabilitation for pulmonary hypertension secondary to lung or left heart disease. And again, perhaps more evidence is required in those with severe pulmonary hypertension. So in terms of the models that might be explored in a little more detail, there's this idea of sort of personalising rehabilitation so that it is stratified absolutely to the individual. adopting possibly a treatable traits approach to pulmonary rehabilitation. We know, and I've been involved in some work in lower middle income countries, that the evidence in these areas of the world is pretty low, and there's no reason really why rehabilitation wouldn't work. But clearly, well, I say clearly, it is likely that these models would have to be culturally adapted to help make them more acceptable. Arguably, you might think that, you know, in a country as vast as America or as big as Europe, there's going to be variations in what might be considered culturally appropriate up and down any of those countries or across Europe. So I think that's something that we shouldn't just isolate to low and middle income countries, but should actually consider on a more local basis as well. We talked about maintenance of pulmonary rehabilitation being, you know, the best model being a little bit vague at the moment. Obviously, various models have been tested, but none of them have sort of conclusively landed on the side of supporting that particular maintenance strategy. Then we've looked at the role of physical activity, tele-rehabilitation after exacerbations, tele-rehab for non-COPD, and that the last point broadly links to the first point, that, you know, if we have all of these models, which model of pulmonary rehabilitation will suit which patient, which to a certain extent comes back down to a model of shared decision making. So you can imagine that all of these queries are sort of culminating in really looking at optimal program components, structure and duration, longer term outcomes, and of course, cost effectiveness, which many healthcare providers are very interested in. So this is the BTS statement, and some of the questions aren't wildly different, but they're not formulated as a PICO. So the 6 questions that we had was again around stable COPD and an exacerbation, but they were addressed in the 2013 statements. We then looked at whether people should, you know, the ATS looked at whether people should accommodate people with ILD, and we in the BTS had that as a section around extending the scope of pulmonary rehabilitation. And of course, adults with pulmonary hypertension would be in that extended scope. When we looked at, the ATS looked at tele-rehabilitation, the section in the BTS guidance was around looking at alternative models of pulmonary rehabilitation. And we also addressed maintenance, but we bundled that up with adjuncts to and maintenance of rehabilitation. So there are some similarities in terms of the topics covered, but we weren't quite so rigorous in defining our approach. So I'm just going to pick out a few things from the BTS that I think are quite interesting and arose in the ATS recommendations as well in terms of areas for improvement. One of the areas that one of the team looked at was trying to understand what we could do to improve uptake and referrals into rehabilitation. And I think this piece of work might have been done by Rachel Evans, who is actually the current chair of the Pulmonary Rehabilitation Assembly. So big thanks to Rachel. I'm not quite sure she's on the call. I know she was in clinic earlier on. But this is some of the evidence where we've looked at what approaches may help referral. And rather surprisingly, that you might imagine that delivering an education package to primary care would actually make quite a big difference. But whilst there's limited research in this area, it didn't result in a massive increase. But integrating approaches to care for COPD did. Delivering education to secondary care referrers didn't really make that much difference, possibly marginally more than primary care, but I don't think we should sort of pursue that as a sort of competition between primary or secondary care. And then we have a little bit of work around discharge bundles. That's particularly a UK focused thing, where it's essentially like a checklist of things to do, particularly around the time of an exacerbation where patients are discharged. So you might imagine it includes checking people's inhalers. Do they need supplemental oxygen? Has that been delivered correctly? Do they have a self-management plan? And have they been referred into pulmonary rehabilitation? And this isn't from either of those documents. This is from a review that Rachel Evans and Gillian Doe did that was published as an accompanying editorial to a paper looking at trying to increase uptake to rehabilitation. And just to remind you, not only do we need this activated patient that you can see on the left-hand side, but we also need an activated clinician to make that referral. So I think those of us that are involved in rehabilitation have quite a bit of work to potentially do to educate, integrate referrals, and perhaps consider more aggressively delivering discharge bundles at the time of an exacerbation. So section 2 in the BTS looked at assessment and outcomes, and I think this very much links to the document that the ATS developed in terms of defining modern pulmonary rehabilitation, which was a pre-pandemic publication, but actually supported the delivery of pulmonary rehabilitation really well through the pandemic and post-pandemic, when we're considering how to deliver different models. So again, if anybody's not read that document, I would absolutely refer you to that. And despite all the challenges with different models of delivery, we cannot move away from a comprehensive pulmonary rehabilitation assessment that looks at people's individual exercise capacity using a validated field walking test, or if people have access to cardiopulmonary exercise tests. And you can't move away from this. There's no evidence at the moment to support the safety or validity of other field-based exercise tests other than field-based walking tests, which is commonly the 6-minute walking test or the incremental shuttle test. And the British Thoracic Society also recommended an assessment of lower limb strength. And we had lots of questions during the pandemic. Could people do a sit to stand? Could we do a timed up and go test? And actually there's no evidence to support that any of these tests that can be used. We're not saying don't use them, but you should only use them to supplement and not replace these validated walking tests. And this is just a reminder of the 2 pieces of work that came out during the pandemic, one by Anne Holland and one by Lindsay Houghton-Woloff, who's most certainly on the call today, looking at the validity of these alternative tests. And, you know, some of the problems are that we aren't sure that we're measuring desaturation effectively in these short-term tests, and that there's potentially a ceiling and floor effect. So we would suggest that at the moment these tests don't offer a viable alternative to field-based walking tests to allow a prescription and evaluation within the context of pulmonary rehabilitation. So we then get on to alternative models of rehabilitation, and you may remember that the ATS came down very firmly on the side of recommending telehealth models. The BTS took a different approach to this, and I suspect this will probably form the foundation of some questions. The BTS suggested that every eligible individual referred to pulmonary rehabilitation should have the opportunity to access directly supervised centre-based pulmonary rehabilitation, recognising that that is essentially the gold standard. If patients decline or drop out, then an alternative model of delivery could be considered. But any alternative model that is delivered within the context of the UK healthcare system should have supporting evidence to really validate its delivery in terms of its clinical effectiveness. And I suspect in every country we've seen a bit of a Wild West in some ways, where people have delivered all sorts of weird and wonderful things during COVID, absolutely with the right intention of supporting people during that difficult time in the absence of being able to deliver formal rehabilitation. But actually, now that we've returned to a degree of normality, we have a responsibility to investigate these alternative models and make sure that they do provide really the value that we think they do. And of course, not surprisingly, staff and patients potentially require support to deliver these alternative models, particularly digital platforms, which may have a rather complex back end for healthcare professionals to manage. Now, the recommendation for the BTS is based on a breakdown of the systematic review that was included in the ATS documentation. So the papers in the ATS statement are the five studies that are on the left-hand side with the red and the pink bar. And then on the right-hand side, we have the McCarthy, which is the Cochrane Review of Pulmonary Rehabilitation. And on the far right, we have the UK National Audit data. And the graph displays the mean change in the 6-minute walking test in the randomized controlled trials, but also in the Cochrane Review and NACAB. And the dotted line represents the minimum clinically important difference. Now, you can see that all of these studies actually failed to achieve the minimum clinically important difference for the 6-minute walking test, with the exception of the intervention, the home-based intervention in the Bourne study. And this was a web-based application. All the other studies, whilst there was no significant difference between these values here, you can see that they failed to achieve the MCID, which made us more cautious within the context of the BTS committee to recommend this technology-based or telehealth-based rehabilitation. So that brings me nicely onto one of the studies that we've just looked at the data for. This was published towards the end of 2023 in Thorax, but it looked at a secondary responder analysis from the original trial that Henrik Hansen published, looking at telerehabilitation versus conventional supervised rehabilitation. So took the original data set and did a secondary analysis. So just to remind you all, this was the first trial where they assessed nearly 400 patients for eligibility, and 250 actually declined because they preferred to participate in a centre-based rehabilitation programme. So then they had their required number of 134 that were randomised either to essentially a video conferencing type rehabilitation programme that you can see in the first picture, or a more conventional exercise-based group that was supervised by healthcare professionals. And just to reiterate the point from the graph taken out of the BTS guidance, you can see here that presented in a slightly different way, but the pre and post data from the telehealth pulmonary rehabilitation programme, which is the blue line, or the supervised rehabilitation, which is the red line, remarkably similar results with very little improvement. Similarly, you can see on the right-hand side that there's not much change in the CAT either. So none of the group improvements exceeded the MCID at any time point. So yes, they were equivalent, but they failed to reach the MCID. So within the text of this paper, the proposal, they suggested that originally the proposal was that home-based pulmonary rehabilitation is equivalent to centre-based, but largely available trials fail to reach the MID. And previous cohort data suggests that actually 40 to 50% don't achieve an MID in conventional pulmonary rehabilitation. So they took known MIDs of a number of common outcome measures, and that's the EQ5D, so there's a typo there, so apologies for that. The 6-minute walking test threshold was 26 metres, so slightly lower than the data that we would be using of 30 metres from the ERS documentation. And they defined a good response as having an MID in three outcomes, moderate 1 to 2, and no response as 0. And this is the data. So the blue is the pulmonary rehabilitation, the supervised pulmonary rehabilitation, and the pink is the telehealth rehabilitation. So you can see that the differences in these various outcome measures. So we've got 6-minute walking test, CAT, HADS, and the EQ5D. And these are the percentages of people achieving the MCID at either 10 weeks, which was straight after the rehabilitation finished, or 52 weeks. And broadly, you can see that the levels are, sort of skirting anywhere between 20 and 40%. And the only difference between groups was for hospital anxiety and depression score with the anxiety components, where the telehealth group had a higher proportion of people achieving the MID. So after that, interestingly, the authors amalgamated the groups and looked at the trends of a good response, which was 3 or more outcomes, compared to moderate or no response at 10 weeks compared to 62 weeks. Now, you can see that 36% of patients had a good response, 44 moderate, and 19 people and 19% had no response. And that drifted a little bit over the year, as you might expect, with 23% retaining a good response, or 17 retaining a good response, some drifting from moderate to good in the Sankey diagram. The majority of people retained a moderate response, and a slightly increased number had no response at all. So the authors sort of proposed that often we don't, in trials when we're reporting, look at the numbers needed to treat, or indeed look at the proportion of people that achieve the MID, and perhaps this is something we should consider rather than just looking at mean values and mean differences between intervention groups. They also then went on to suggest that the McCarthy-Cochrane review actually, 1 in 3 trials failed to reach the MID for either the 6-minute walk or health-related quality of life. And then talked about the difference between pulmonary rehab and bronchodilator therapy, suggesting that actually the numbers that achieved an MCID for bronchodilator therapy is actually even smaller than it is in pulmonary rehab. And it's a slightly interesting comparison, because actually they were comparing it against a control group, and their paper obviously was comparing 2 different types of interventions. And I've just put 2 graphics at the bottom, which is taken from our UK National Pulmonary Rehab data. So obviously cohort data, it's real world data, but we were able to show a 65% of participants secured an improvement above the MID in exercise capacity, and almost similar numbers in terms of health status as well. So we sit within what the authors have suggested, or slightly above what you might expect in cohort trials. So I think that it's quite interesting, isn't it, that you've got randomized controlled trials that never perform as well as cohort data. And we have to ask if that's a problem with trial design. And do we need to consider new trial design? And Anne Holland and I have put in several proposals to the ATS for workshops to look at trial design, and have singularly failed to get it approved. But I think increasingly, with new models of care coming along, this is something that we do all need to think about, and a conventional RCT design might not be the right type of design, because inevitably people that are recruited into, say, the Hansen study have to be willing to do either the telehealth model or the conventional model, and usually people come with a preference for one or the other, i.e. they can't get to rehabilitation, would rather do it at home, or would actually prefer to have supervised. So I think that, going back to one of the points in the ATS document, we do have to try and work out which is the best intervention for which person, and I'm not sure that an RCT allows us to do that necessarily. They also suggested that a single endpoint for a complex intervention is probably not fair, and perhaps we need to consider a composite outcome in terms of, and then went on to suggest that a core outcome set should be adopted. Which brings me nicely onto the last paper, which absolutely looked at a core outcome data set. And this was a piece of work from largely Portuguese authors, led by Alda Marques, but obviously supported by Martin Spruit as well. So this very much followed the international guidance around developing a core outcome data set. So the principles behind that were obviously sort of half introduced in the Hansen discussion, but we know that there's a large variety of outcome measures applied in the published research. It's a bit like comparing apples and oranges sometimes when you're looking at different interventions. And in terms of service delivery, it becomes really difficult to benchmark in terms of where good services are if we're all using slightly different outcome measures. So there's a real need for a standardized approach to shift the field of pulmonary rehabilitation forwards. So obviously this team went on to develop a core outcome data set, ideally supporting consistency across trials, which allows you more effectively with bigger numbers to do meta-analyses. It reduces reporting bias and allows this benchmarking and quality improvement initiatives. Even if you're not going to do research, you can learn from people in your area if their results are better than yours, or they can learn from you if your results are better than theirs. So there was a lot of background work to this. They'd done a previous systematic review and some qualitative work to really inform the list of outcomes. And from the systematic review, just to make the point, they found 163 different outcomes reported for pulmonary rehabilitation, which they condensed into 57 because they were, largely of a similar category. And they developed a very nice web tool that was translated into a number of different languages and circulated widely. And they had two groups of people. They had healthcare professionals, including clinicians, researchers, and policymakers, and then a group of patients and carers. And they used a 9-point Likert scale, where 7 to 9 was considered critical and 1 to 3 not that important. And to be included, the data had to be scored 7 to 9 by more than 70% of the population in both groups and less than 15%. And then measures that were deemed important only by one group were taken forwards into a discussion forum. And this is the sophisticated but actually guided process that they went through. So you can see those 2 rounds with 300 participants, or almost 300 participants, and they retained a huge number of participants. So they had 250 in round 2. So in round 1, they had 6 suggested outcomes, but by round 2, they'd excluded 43, 14 were inconclusive, and 6 outcomes from the Delphi were carried forwards. So this just summarises that lovely graphic out of the table. One of the problems was that although they had a wide reach, there were no low and middle income countries included, which is probably important given the ATS guidance around developing rehabilitation in low and middle income countries. So these are the items that came through in round 1 and round 2. So we have dyspnea, exercise, health-related quality of life, impact of the disease, which was sort of originally termed as problem ADLs. And that was supplemented in round 2 by fatigue and lower limb function. So there's some interesting variations in terms of priorities in that 70% of patients and 33% of healthcare professionals thought lung function and respiratory muscle function was crucial. Anxiety and depression didn't make the cut in either group, but the authors did note that we should still consider that. And healthcare professionals voted for the inclusion of exacerbations in round 1 and 2, above the 80% threshold, but users didn't, which is interesting because the data from Jenny Quint's group would suggest that actually rehabilitation struggles to directly impact exacerbation rates at the moment. And then the authors included 3 additional items at the point of discussion where the healthcare professionals deemed them to be important. So that was patient goals, patient knowledge, and health behaviours. So Apart from the other 6 items that were identified as part of the Delphi, these were subsequently added, but it was noted that they would require further work. So this is the final list of core outcomes, and they divided them up into sort of physiological or clinical outcomes and then life impact outcomes. So just to summarize, dyspnea, fatigue, exercise capacity, lower limb function, health-related quality of life, problematic ADLs, and then healthy behaviours, knowledge and personal goals. I think it's quite interesting, and the authors noted this, that actually they're fairly generic outcomes that could be applied across a number of long-term conditions. And when you looked at core outcome sets for other long-term conditions, they are remarkably similar. So it was a very robust methodology, 9 core outcomes, large group of participants, limited representation in low and middle income countries. But of course, the challenge is, which measure do we use for these domains? I think there's a big piece of work now to get some agreement on which health-related quality of life measures we should use, which functional exercise capacity we should use, and then how are we going to encourage everybody to actually align with this core outcome data set. So, in summary, I think it's been a good year for pulmonary rehab. There's been new evidence-based guidance and clinical statements, but the post-pandemic has highlighted the need to increase the scope of rehabilitation and consider alternative acceptable models. I think we've got enormous challenges with trial design, and I'm not convinced that a one-to-one randomization of individuals willing to accept either intervention is appropriate. But I think overall, the future is very rosy for pulmonary rehabilitation, and lots of great work has been done this year. And I will leave you with the reference list for the papers covered today.
Thank you so much, Professor Singh. That was lovely and very comprehensive. I do want to open it up to our participants for questions. I think maybe we can start with a question that came up in the chat. I believe this came up when we were discussing ILD and the BTS guidelines about, do we have recommendations specifically for silicosis?
No, I don't think we do. We have within the ILD, in the broader ILD, but we haven't, I don't think there's much work very specifically in silicosis. The other area that there was a letter, wasn't there, to the Blue Journal looking at post-TB lung disease, which is an interesting question. There's certainly been data to show that people with post-TB lung disease have functional limitations and a disrupted health-related quality of life. But we don't have any trials in that area either. I think there's data that's going to come, but we don't have any data very specifically in that population yet. I think it's a watch this space area, but we don't have it in the public domain yet.
Yes, very good point. And I think kind of blends into a lot of what you discussed here, which is that there's so many, I mean, COPD we really know and understand, but all of the other diseases that can be treated in pulmonary rehab really can present in a number of different ways and have a number of different complications. And, diagnoses like just ILD, right, really can encompass such a variety of different complications and presentations of disease. Yeah. Great. Go ahead, Lindsay.
Thanks, Katie, and thanks, Sally. I know you said it's been a long time coming, this session, but it was worth the wait and still very relevant papers, so thank you. I know you commented a bit on this, but could you say a bit more about the discrepancy for the tele-rehab recommendation between ATS and BTS? I mean, do you think that's because they're different methodologies in that obviously one's a guideline and one's a statement, or were there other factors involved?
No, I think you're right, Lindsay. I think that, and it is interesting, the difference, isn't it? But the approach of the ATS is to take, the best quality evidence which we currently believed to be systematic reviews. So there were a small number of studies that looked at telehealth interventions, and interestingly, within those offers, the models of delivery were quite different. So again, it's quite difficult to unpick what might be more effective than not. Now, because these trials were largely set up as equivalent or non-superiority based trials, the analysis is looking for no difference between the groups. So when you do a forest plot, you don't find a difference between the groups, because if you think about the Hansen graph that I showed you, the two groups tracked remarkably similarly. We sort of dissected that down a little bit for the BTS and actually did plot the differences. So then we've got the Hansen study that was included in the Cochrane review that concluded that telehealth should be considered as a viable alternative. And then in the introduction of his paper, he said telehealth models have failed to reach the MID. Now, because of the subtleties of the analysis, you don't know whether, on the whole, whether those interventions have achieved the MID. But we sort of took a step back and looked, I wouldn't say at the raw data because it's mean data. So I think that's the difference, and why, despite the fact we've used the same data, it's been interpreted differently. One, because of the rigors of doing evidence-based guidance, and secondly, a little bit more freedom associated with the BTS statements.
Yeah, I think that's right. It's looking more at the detail, isn't it, rather than just the headline. And but otherwise, it's quite confusing as a clinician. If you look at both, it's what do we do?
I think it's very confusing. And there's not a whole wealth of data around tele-rehabilitation models. So I think there's a lot of work that we need to do in this space.
Thank you, Lindsay. Suzanne.
Hi, good morning. Thank you, Sally. Hi. Nice to see you. And you've done work in the past on what patients have thought of as outcomes. And we've kind of skipped over that over the years. We've focused on the sets that we think are important to the patient. But what are your thoughts about starting to integrate patient desired outcomes in our mix? There might be more value since we're doing it for the patient.
Yeah, no, I think that's right, Sue. And I think to a certain extent, the variables that were added in by the authors to the core outcome data set probably reflect that a little bit in terms of patient goals, healthy behavior and lifestyle. So I think that there's been an acknowledgement of that. I think it's becomes very difficult to standardize some of these sort of more patient-focused ones, which is a real pity, because actually that's why we're all doing it. Having said that, the payers would rather we showed that something was cost effective. So I think there's always that balance, isn't there, of absolutely delivering what the end user wants so that we have a service that is absolutely acceptable, but also delivering a service that is cost effective and adds value to the wider health economy and society. So I think it's a real challenge, but absolutely we should focus on what patients want to be able to do.
Yeah, great points. And I think this was right. This was a discussion too at last year's meeting, is really focusing more on patient-related outcomes. Pop to the chat real quick, unless anyone wants to raise their hand to ask a question. But Nicola asks, to keep things moving along, what do you think are the key areas that we need to focus on this year around pulmonary rehab?
So my sense is that the demand for rehabilitation is huge. And with supervised rehabilitation, we're only really scratching at the surface. I also think that most of us involved in supervised rehab think that's the best model, and I think to a certain extent the data would support that. But I think we need to explore other models. Now, that may be I think the swing at the moment is to assume that everything has to be digital. Now that there's a survey conducted in the UK by Will Mann's group that shows that in the UK, people have very little appetite for digital-based interventions. Now, we ran a similar survey in India, and actually people wanted digital interventions as a priority, or an alternative home-based intervention with a manual or something like that. And very few wanted centre-based rehabilitation, because traveling is a nightmare in India. I mean, it's quite bad in all cities, isn't it? But it's on a different scale in India. So I can absolutely understand why people may choose that. So I think that we need to understand a broad group of potential users, not just the users that we see coming to rehab, because the reality is there's more people we don't see than we do see. And we get a lot of satisfaction as healthcare providers from the patients that we do see, and sort of forget the ones we don't see, because it's a bit difficult to work out what we might do with this group of patients. But I think that the COVID pandemic has really forced us to think about different models of care, and they may be absolutely different, or they may be hybrid models. So I think there's a whole new research agenda around really establishing the value of different models and how we may work out which patient is best suited to which model. And it may be as simple as asking the patient which one they would prefer to do, rather than us as healthcare professionals thinking we know which is the best one to do, once we've accumulated the evidence to show that they are effective.
Great point. The next question is kind of two parts, so I'll ask the first one. Are there any published protocols or recommendations for strength testing of these pulmonary rehab patients?
So, I mean, that's an interesting question, or a very interesting question. We've just embedded it into our BTS guidance to do that. We also have an accreditation scheme that is supported by the Royal College of Physicians in the UK. And we have a frequently asked questions section on that, very specifically about measuring leg strength and prescribing exercise, because we're not very good at that in the UK. I know in many parts of Europe, they're much better at it than we are. So we're trying to shift the dial a little bit on that to get people a little bit better. So we've been looking at 1RMs and various calculations that you can use from a 1RM, or use not a sophisticated, Cybex type dynamometer, but just a handheld dynamometer.
Well, that actually leads into the follow-up question. I'm not sure if you saw it, but how do you feel about the dynamometer and measuring to use peak strength?
Well, I think obviously if you've got a Cybex, that is the gold standard. But I mean, outside of the research setting, it is highly unlikely that that is going to be used. Equally, a lot of centres don't have access to gym-based equipment where you do necessarily a 1RM. So I understand that it's difficult. And a handheld dynamometer is probably one of the easier ways of measuring lower limb strength. But clearly, as the population, if you have a younger population, you have to make sure that you're able to provide adequate resistance.
Yeah.
And we've got some great pictures on some of our training programs with Claire Nolan, who I'm sure is a name that's familiar to many of you, sort of wedged up against a wall as the patient is pushing out with a handheld dynamometer.
Connor had their hand raised and had asked that question, so I just wanted to.
Yeah, that's all right. I'll just come off.
Yeah.
Hi, Sally. It was really cool to listen to that. I'm a bit of a fan after reading all your papers. Yeah, we're going for accreditation and really trying to push for the strength testing.
Yeah. We're
a community-based pulmonary rehab service, and as you've obviously just said, like there's a lot of limitations for us. I specifically, because it's coming up with it looks like a few people are querying this kind of thing, and about an actual protocol for strength testing, because the statement obviously is telling us to do lower limb testing, which is important for an outcome measure, but for prescription as well, if that's possible. But I think a lot of people are struggling to find the best way to do it in the community. So I'm thinking about dynamometry of a leg extension while seated, and then using that as 1 rep max to prescribe a percent. Do you see any issues with that?
No, I think we, as broadly as part of your accreditation, that would be accepted. And I guess people outside the UK aren't quite so familiar with this accreditation scheme, but it's a way of ensuring quality of rehabilitation programs, Connor. So I'm just giving it a little bit of context for the sort of US or European audience. It's a bit like the AACVRP accreditation, but recently a measurement of lower limb strength has been added. It was sort of would have been nice to do before this BTS guidance came out, but it is likely that the standards will be revised and lower limb strength will be added into the standards. It isn't in yet, Connor, but it is highly likely that it will be.
Okay, that's useful to know. Thank you very much.
There's Gail's just put in the link to a paper, which is probably worth a look.
Oh, brilliant. Thanks, Gail. Thank you.
And there's also an FAQ on the RCP website.
Great discussion. So Alan posted a very great comment, I think, to follow a lot of what you've said, Professor, but outcomes that matters to patients. Maybe we need to think about outcomes in relation to our audience and decision-making required of that audience. So outcomes that inform patient decision-making may be different to outcomes that inform regulatory decision-making, which may be different from outcomes that inform payer decision-making.
Yeah.
Which is great.
No, I think that's absolutely right, Alan. We sort of try and bracket up our outcomes to the patients. Us as healthcare providers, what do we need to know to show that we've been effective? And then the payers, what do they need to know? And that's, of course, largely around reduced admissions, reduced presentations of primary care, etc.
All right, we have a question from Rafael, who's here from Brazil. Thank you for your comprehensive presentation. I'd like to ask your opinion about best measures to assess health-related quality of life in PR. The most common instruments, such as the CRQ and the St. George, have been used and tested only in a limited number of diseases, but patients assisted in PR are becoming more and more diverse. Do you think that we need to develop a new instrument that is PR specific rather than disease specific?
It's an interesting question, isn't it? I mean, years ago when I first started, we used to have this debate over generic or disease specific, and the generic one was usually the SF-36 that was debated in respiratory world. And we've just started a trial back in the UK that is looking at a very diverse population that extends beyond respiratory, and which is sort of related to the question, isn't it? Because it's quite a mixed population. You've got respiratory, but also people waiting, lung cancer, and people waiting for surgery with a restrictive lung disease. And we spent a lot of time talking to patients to see which outcome measure they would prefer. I mean, we gave them a limited choice because there's not that much to choose from, is there? But they absolutely hated the SF-36. And they, interestingly, we obviously had very well-informed patients on this panel because they hated it because patients hadn't been involved in the development of it. So they'd obviously gone back to the source literature and decided that, quite rightly, it was done before we had patient involvement like we do now. So they absolutely binned the SF-36. And we're now using the EQ5D. Now, the BTS guidance, which I didn't particularly go into, but it also identified that extending the scope of rehabilitation, we could go to chronic heart failure, the ILDs, possibly long COVID, pre and post surgery. And we did a survey of which outcome measures people were using around the UK. And it was largely the CRQ or the CAT. We don't have much data on the SGRQ, but we made a decision centrally to add in the EQ5D as a more generic health-related quality of life measure. One, because it's easy to do. Secondly, when we spoke to NICE, they were very keen, and NICE is our governing body that looks at health, the value of healthcare interventions and makes recommendations to our health service. But they were very keen that we added in the EQ5D. So now we've done that as our sort of generic measure, which is interesting because if you think about the core outcome data set, one of the comments they made was they're all quite generic measures, and there wasn't one that was, I guess that dyspnea is disease specific, but generally speaking, they could be applied to any long-term condition, because we know that breathlessness is also a symptom of many other long-term conditions and deconditioning.
That's great. So a few more questions. How relevant is it to be measuring pulmonary rehab education and knowledge improvements? Do you feel that the BCKQ remains valuable 18 years after being published?
Well, I think there's some elements of the Bristol Knowledge Questionnaire that perhaps aren't relevant now in terms of pharmacotherapy type management in what it's asking. And I think, that knowledge was a topic that came out in the core outcome data set. And we've really only got the Lung Information Needs Questionnaire and the Bristol Knowledge, to my knowledge. And I suspect they both need revisiting. And if Jean Bourbeau was on the call, and he might be, I don't know, but he would say just because you have knowledge, it doesn't mean that translates into good behaviour. So to a certain extent, I think we need to work out what we're trying to influence and therefore what we should be measuring.
Yeah, for sure. Okay, and so being cognizant of the time, I think we'll try, there's a great comment from Michael Bellman about how comorbidities complicate our outcomes in pulmonary rehab, but I think maybe one question we could leave this discussion with as we are wrapping up is, were there any outcomes included or discounted in the core outcome paper that surprised you?
Well, I think the hospital anxiety, hospital anxiety, the fact that anxiety and depression wasn't included, because, around the globe, everybody's recognizing the importance of mental well-being. So I was fascinated that wasn't included. And as Michael said, well, not quite said, but, mental health is a really important comorbidity that a significant proportion of patients come to for pulmonary rehabilitation.
Yes, definitely. Okay, well, I think as we wrap up here, I just want to take the opportunity to thank Professor Singh for your contributions and your expertise here today, and just being able to be involved in a lively discussion. I'd also like to thank the audience for listening and interacting, and especially to Miriam Rodriguez at the ATS for all of her help with organizing this journal club. We'll announce our next journal club in due course and hope to see you at that one. Thank you and have a good day.
Thank you so much.
Bye-bye.
If Sally's, Dr. Singh is still on for a minute, I just had a quick question, and I know it's really at the end. I just have a quick question about the people running the rehab programs, Dr. Singh. Does it make a difference? Have you found, because in different parts of the world, it could be physios running rehab programs, or it could be certified respiratory educators whose background might not necessarily be in rehab. Has anything like that come up in different parts of the world as to the outcomes of patients depending on who it is that might be running the programs?
So I think that's an interesting question, because the World Health Organization did their review of rehabilitation and recognized that probably not enough staff around globally to run rehab. So there was a need to look at arguably unqualified staff running rehab programs. So I think that is an issue. All of the guidance is for there to be a qualified healthcare professional in the room, and certainly the work that we've been doing in low and middle income countries, that has still been the case, and that we've always had a healthcare professional in the room. Whether that, stays, indefinitely, then, I don't really know. But I think it's a real issue, isn't it? But we have unqualified staff manning our website programs after qualified staff have done the initial assessment. So I think there's absolutely a role for unqualified staff to support people. I think the assessment is crucial, and for the foreseeable future, I think that needs to be done by a healthcare professional, not least because, like Michael said, people are becoming more and more complex with multiple comorbidities that probably needs, that detailed assessment, and then can be probably managed in some scenarios by unqualified staff. But I think that needs a lot of work.
Thank you so much. I'm such a big fan. Thank you so much. It's good to hear you.
Pleasure.
Thank you.
All right.